topic is etiology and magnitude of obesity and why and how should obesity be treated. So, Ms. Sneha Raje is a lifestyle coach, founder, Build and Bond consultant, a renowned nutritionist. Dr. Ms. Sneha, please.
Good morning, all. I hope I'm audible to everybody.
Yes. Yes.
Thank you. Thank you for having me here. And I hope I would be able to do justice to the topic. I wish everybody a very good morning on a Sunday morning. I will just try and present this my screen. The topic that I would be speaking about is etiology and management of obesity. Why and how should obesity be treated? Obesity is a multifactorial chronic disease. So we have it is defined as an excess of adipose tissue that imparts health risk. A body weight of 20% excess over ideal weight for age, sex, and height is considered as health risk. If we look at obesity and BMI, BMI is considered as the gold standard for measuring obesity and is the most widely used scale to gauge obesity, popularly known as the BMI. And most people would ask or kind of mix with BMI and BCA, which are two different things, and we would look at it in a while. BMI is equal to weight in kgs. Divided by height in meters square, and a cutoff for BMI value is of 30, which is used for obesity both in men and women. Now, a little deeper look at what BMI would say is the WHO has recommended that anything more than 30 would be considered as obese category. 30 to it would be moderately obese, 35 to 40 would be severely obese, and more than 40 would be moderately obese, morbidly obese. But the Asia cutoff is a little different and a little rolled down because of the genetic predisposition to carry higher fat percentages. And the nutritional status, according to the Asian category, the obese category starts right from 25 as compared to 30, and 20 and grade 2 obesity starts at more than 30 itself. There is a direct correlation between the higher ranges of BMI and higher fat percentages. So higher the BMI, especially more than 30 BMI, it is directly proportional to carrying higher body fat percentages as well. Dr. Poonam would be addressing this at more detail after this talk. So what the etiology of obesity, what causes obesity? Prima facie looking at the surface, it is an imbalance between calories consumed and expended. Globally, there has been an increase in the intake of energy-dense food that are high in fat and sugars, and an increase in physical inactivity due to increasingly sedentary nature of many forms of work, changing modes of transportation, and increasing urbanization. But this is just one aspect of it, or probably just the surface of it. And obesity, that we would know, is multifaceted and a combined product, a combined impact of many different aspects as biological, behavioral, and environmental. Mostly the aspect that we address or we get to see or is more prominent or caught is the behavioral aspect, where there is excess of calorie intake, eating patterns are different, there is sedentary lifestyle, reduced physical activity, insufficient sleep, and smoking cessation. So a lot of people who would try losing or giving up on smoking have also experienced weight gain. So that is one thing that we would want to prime our patients when we say then they're attempting to reduce smoking. These are the behavioral aspect. But what is happening from the external environment that is actually nourishing this or kind of providing an impetus to increasing the obesity is food abundance. There is a lot of food that is very easily available. The every shop would have at least some kind of food to eat, the biscuit or a sweet, anything. And food is so very easily available. So a couple of times when patients say that I hold a Swiggy and I have multiple food apps on my phone. Probably just giving up on those apps have caused them to lose weight. So that abundance food it is. Social economic status and culture. uh, Culturally we are primed to look at, we like to look at chubbier babies, and that is one of the reason that uh, obesity had its little feet coming in there. There is biases and discrimination, and environmental chemicals that would add to obesity. But what is happening inside the body with the behavioral and environmental aspects coming together is the play of genetics, the gut-brain barrier axis that promotes it. There are prenatal determinants as the weight of the mother, the weight of the father, the stages of life as pregnancy, menopause will promote weight gain, neuroendocrinological conditions, role of different hormones, medications that would promote any physical disability or accidents, gut microbiome, or even viruses. So all of these have their own impact or contribution to leading obesity. A little extension of the interplay that happens between environmental or societal and the biology is the genetics, the epigenetics, the internal clock, inflammations, the weight cycling. There are sportsmen, athlete, or people who would repeatedly gain weight, lose weight, and that also increases the number of adipocytes, the adipose tissue expandability and distribution, the amount of brown fat, white fat, the brain and central rewarding system. Food is often considered as a reward, and all occasions have to be present. All parties will be accompanied by some form of a sweet or high calorie food. There are neurocircuit appetite and satiety regulations that is happening, addictions, sarcopenia, as well as psychiatric disorders that would impact or interplay with the cultural patterns, the various transportation forms, the ease of moving around, smoking, computer games, increase of virtual environment, social media impact, food marketing. All of these have an impact on the way the energy is metabolized and energy expenditure happens. They actually would determine our physical activity rate and food intake as well. And depending on how the how they are placed, we would either gain weight or lose weight. So what is the magnitude of obesity? How much does it impact, what it is doing? So if we look at the global aspect, worldwide obesity has tripled since 1935, and that's a huge number. In 216, more than 1.9 billion adults 18 years and older were already overweight. Of these, over 650 million were obese. 39% of adults aged 18 years and were overweight in 2016, and 13% were obese. Most of the world's population living in countries where overweight and obesity kills more people than being underweight. 38 million of children under the age of 5 and overweight in obese in 2019. Over 340 million children and adolescents aged 5 to 19 were overweight or obese in 2016. If we look at countries like India, it is very common to see the dual burden of malnutrition, where one end there is severe undernutrition. At the same time, we are also facing the repercussions of overnutrition. That was a global picture. Let's look at what is happening in India. Indian adults aged between 29 to 69, it is kind of predicted that between 2010 to 2040, it would be double. The overweight category would get double, and there would be prevalence of triple the number of obesity that would be prevalent. There would be, and the substantial increases among rural and older Indians is becoming prominent. This is what the graphs are trying to tell us, that in the urban or earlier, the the older age above 50 had lesser prevalence of gaining weight or being obese, as compared to now they are at a higher range. The similar trend is seen even in the um, rural areas, where obesity has been lower in the earlier years, and then there would be more of adults would, elderly who would get into obesity zone. Why is it required to treat obesity? So we would definitely know that there are complications that obesity comes along with. We would be dividing into two aspects as metabolic and more of mechanical. The metabolic complications, where there is an complex role of hormones playing, with the adipose tissue being an active tissue and releasing hormones and having an interplay on the endocrinology of the body. Type 2 diabetes, the incidence of type 2 diabetes has increased. The hypertriglyceridemia, low LDL cholesterol has also increased. With obesity, there is higher chances of hypertension, with more than 26% of hypertensive and more than 28% of hypertensive men are obese. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis is also an outcome of obesity, with higher fat depositions in the liver. Inflammation, obesity by itself is known as pro-inflammatory, and there are inflammatory markers that would be released. Hyperuricemia, a lot of patients come in with increased uric acid, and probably they start blaming it for the higher proteins in the diet, but obesity plays a very significant role in the way the hyperuricemia is pronounced in the blood. There is insulin resistance which would come in, of course, polycystic ovarian syndrome, and pregnancy related complications, where GDM, 1 in 5 women come into the clinic with are diagnosed of GDM, which is a very high proportion. Looking at the mechanical complications of obesity, gastroesophageal reflux disease, the loosening of the sphincters, the acid refluxes are increased with increase in weight and obesity. Obstructive sleep apnea, a cyclic feature where the obesity would contribute to OSA, as well as OSA increasing the sleep obesity. Degenerative joint diseases, where higher the weight the joints have to bear, they would be degenerated furthermore. With this, we would also want to look at a little special aspect. With childhood obesity increasing so rampantly, there are psychosocial impacts. There is poor self-esteem, kids are depressed, eating disorders have become very prominent. There are neurological disorders, pulmonary disorders like sleep apnea, breathlessness. There is exercise intolerance. There is lesser activity, and kids just are tired with very short activities. All the more with staying inside home, this is increasing. Cardiovascular diseases, is dyslipidemia that is seen in children's, hypertension, coagulopathy, chronic inflammation, and endothelial dysfunction. There are renal impacts, musculoskeletal impacts, improper bone formation, endocrine disorders like type 2 diabetes, precocious puberty, polycystic ovary in girls, ovary syndrome in girls, and hypogonadism in boys. How do we treat obesity, since the magnitude is so high now? The objective of the treatment of obesity is to improve overall health and quality of life of patients. We'll try to minimizing complication and curb the progression of comorbidities. It tries to achieve weight loss to a clinically meaningful degree that patients and clinicians will embrace initiation of anti-obesity therapy. To plan weight management or weight maintenance to a degree that patients and clinicians will persist in adhering to long-term and anti-obesity therapy. There are 5 A's of obesity management, and this would kind of plot for us to work with our patients, where first we ask the patient the history. What are the lifestyle factors that what are the lifestyle habits that the patient has? Is there an awareness about it? Is there a readiness to change? Assess if there are, what are the root causes and influence factors, the risk factors and complications that are there. Classifications and staging of obesity. Advise by the means of benefits of weight loss. Advise them need for long-term strategy, because it is not an overnight phenomenon that something is done over for 2 to 3 days and then you would be okay. There are the various treatment options that the therapist or the doctor can advise and work with the patient with. Get agreements on expectations and outcomes of the treatment. Get agreements on goals and the motivation that the patient has, and work with the patient to have a treatment plan for them. Patients are well read and they would want to know every details of the treatment now. So we will have to understand this, and we have to take into account this part, assist the patient with the drivers and what are the barriers in his, provide knowledge and resources where the patient would like to read up, and definitely referral and follow up. Being so much of a multifaceted aspect, we would definitely require a teamwork to work on obesity. So obesity management is not a blanket treatment, but more of an individual treatment plans where nutrition therapy, physical activity, behavior therapy, pharmacotherapy, and bariatric surgery can be placed as a part of the cake, and wherever required, one precedes the other, and all of them together can make a wonderful treatment. Balanced nutrition planned can save the patient from different deficiencies that might come up. Physical activity is definitely required. Most important is to protect the patient while they are being physically active. Behavior therapy, motivation and sustained motivation is an important part of losing weight and reducing fat from the body. So behavior therapy and the role of psychologist here is definitely pronounced. Pharmacotherapy, role of medications and placing them at the right time. And of course, bariatric surgery is one of the prime areas where people are also resorting to and would like to work on obesity. Use of pharmacotherapy as a part of comprehensive program should be practiced. When to initiate weight loss in medications in patients with overweight and obesity. So to initiate, always lifestyle therapy has been advocated, and with no complications, patient with obesity or overweight who have no clinically significant weight related complications, they would like to work more on the nutrition and physical activity aspect. When there are mild to moderate complications, patient with mild to moderate weight related complications, lifestyle therapy is anticipated, and they can achieve significant sufficient weight loss so that the complication is comes down. But failure and progression to a severe zone would definitely account for a medication to be in place. Add a medication for patients who have progressive weight gain or do not have achieved clinical improvement in weight related complications on lifestyle therapy alone, and they would definitely benefit with this. The weight regain on lifestyle therapy is happening. So after a phase of weight loss, the patient regains weight, and then to help the patient stay in the safe zone, a medication can be planned. The presence of weight related complications and comorbidities is also a aspect to consider medications. So for prescriptions for medication, FDA has approved 5 drugs for now: orlistat, lorcaserin, phentermine, and topiramate, naltrexone, and buprenorphine, and liraglutide. An ideal anti-obesity drug would produce sustained weight loss with minimal side effects. So I would like to conclude with nutrition, adult learning and patient engagement, behavior modification, activity, medication management, and surgery and procedures. The patient and a team working with the patient will definitely benefit the patient and will help him combat obesity. Thank you. I would like to thank all of you for having me here. And I hope